these last two slides would be scored exactly the same. You can actually, if you look closely, you can see some of those deep waves. Now, these faster waves that we're seeing are these alpha wave intrusions. And obviously there's a marked difference between the last slide and this slide. However, unfortunately, if a sleep lab is not particularly interested in this phenomenon and is looking for this phenomenon, then those two studies would be scored exactly the same. And I think that this is something that we're beginning to address as a sleep community, but we're a little far off from developing a consensus. Next slide, please. So this slide is a picture of a 30-second epoch from my sleep lab. This is a computerized hypnogram, and at the very top in black we see the EEG pattern. And you can see that this person is in a typical slow wave sleep or delta sleep, deep sleep, and you can see the deep waves. However, you can also see the faster frequencies that are being marked by the computer. And this is a technique called quantitative EEG analysis. This is typically used in research protocols when we look at epilepsy patients. However, there's very little work being done applying it in this way to people during sleep. But using the quantitative EEG modules, one can develop a very quantitative and computer-generated analysis of this EEG alpha intrusion phenomenon that is quite easy to score, and it's very reproducible. And if we go to the next slide, we can see how impressive the results look. So this is a what's called a full hypnogram of a patient with severe sleep apnea. So this is when we do a sleep study, this is what we look at. If we look at the blue, which is the third line down, this is the oxygen desaturation curve. So we can see that this person starts off at 100% oxygenation, and then within about an hour or so, he dips down into the 70 percentile range, and this is very dangerous. The red and the pink are the amount of times the patient stops breathing. And then a little further on, the technician recognizes this person has sleep apnea, so he puts them on the CPAP, continuous positive airway pressure. And as soon as he goes up to 11 and 12 centimeters of pressure, the red and purple lines go away. That means the apnea has stopped, and the blue line, which is the oxygenation, stays normal again. Now, if we look at the top two lines, we see an alpha intrusion line and a delta line. So we see that the person is getting some delta sleep, which is good because we like to have delta sleep. But the top line is flat. Now, what's interesting about this is that this is a patient who has very severe obstructive sleep apnea. They're having significant heart rate variability. They're having oxygen desaturation. Yet even as clinically disturbed as this person's sleep still is, there's absolutely no alpha wave intrusion. Let's compare it to the next slide of someone with fibromyalgia. And you now can clearly see that whenever this person is getting any kind of a delta sleep, that there's significant alpha wave intrusions. Now, for something that some sleep specialists say they've never seen before or don't believe exists, I think it's pretty easy to identify alpha delta sleep in this patient with fibromyalgia. If you look down at their sleep study, in the blue, they're having normal oxygenation. Their sleep state is very typical for fibromyalgia because they do not get into that deep sleep at all, just one little bit before 1 a.m. in the morning, and the rest of it is light sleep and REM sleep. And they don't really have much in the way of obstructive apnea or leg movements. But again, if we look at the top two lines, the pathology in this particular case is very, very clear. Next slide, please. The National Fibromyalgia Research Association actually had a conference concerning fibromyalgia and sleep disorders back in 2008. And I thought that was very interesting because there's not been a whole lot of people who've been interested in sleep and fibromyalgia. But for a group like the NFRA to host an entire conference on the topic, I thought was very bold. and it was a very, very informative topic. I was actually present there to present some research in this area, and we can go to the next slide. We can take a look at that. What I did using this quantitative EEG analysis is create a ratio called the delta alpha event ratio. And if you look on the left screen, from 0 to 30, most people with fibromyalgia, and these I studied 5 patients in particular, had a delta alpha ratio of around 5 or less than 5. And in most people without fibromyalgia, their delta alpha ratio is usually 20 or higher. So this is a very simple tool to recognize patients with fibromyalgia. But because we know that patients with fibromyalgia have this alpha-delta sleep and they have a lack of deep sleep, what we did is experimented with a medication called sodium oxybate. It's an experimental medication which is actually FDA approved for narcolepsy, but it improves deep sleep and reduces alpha wave intrusion. And so we wanted to see if not only could we use quantitative EEG to identify patients with fibromyalgia, but if we could use this quantitative EEG to assess if there was clinical improvement based on an intervention. We give these patients sodium oxybate, and then we measure their pain scores afterwards. And we can see on the right graph that their pain scores all dropped. And on the left graph, we can see that their delta alpha ratios all improved. So not only, if we can go to the next slide, please. So what we concluded is that sodium oxybate in particular may be an effective treatment for the dysfunctional sleep as well as pain of fibromyalgia, and that the improvement in both pain and sleep supports the general association between pain and slow wave sleep. And lastly, that quantitative EEG during overnight polysomnography or sleep studies may be a useful surrogate marker for the treatment response in fibromyalgia. Next slide. So what is sodium oxybate? Well, sodium oxybate is actually a gamma hydroxybutyrate, or GHB. It's an actually normal or what we call endogenous occurring molecule. So your brain actually makes GHB, and it may be a precursor to a chemical in the brain called GABA. GABA is our one neurotransmitter that is a downer. It relaxes the nervous system. And GHB is either related to the production or the breakdown of GABA. It is approved for the treatment of narcolepsy and cataplexy here in the United States. It increases slow wave sleep, and it increases growth hormone. And this is because growth hormone is mainly pulsed during deep sleep. What is interesting, and we didn't discuss at this particular time and beyond the scope of this particular lecture, is that growth hormone also happens to be low in the majority of patients with fibromyalgia, and probably is a reflection of their poor slow wave sleep. When you increase their slow wave sleep with the use of sodium oxybate, their growth hormone levels also return to normal. Next slide. Following this, the pharmaceutical company Jazz did a study looking at sodium oxybate in fibromyalgia. This was a large 548 patient trial study, phase 3, performed here in the United States. I was one of the investigators at 74 sites across the United States. And they broke these down into 3 groups. One group got 4.5 grams at night, another group got 6 grams at night, and the other received a placebo. And what they wanted to do is see how patients would respond in terms of pain as well as sleep and fatigue, as well as some other variables when given these products. Next slide, please. So in this first slide, this is a pain visual analog scale. And so obviously negative is better because there's less pain. And in the top line, the black line is placebo, and in the blue and red line are the treatment groups of sodium oxybate, 4.5 as well as 6 grams. And you can see that already by week 1, there's a statistically significant deviation from the placebo group for the treatment, and this is something that's very unusual to see in a study at 1 week, to see a statistically significant difference, which of course improves throughout the study and maintains its statistical significance throughout the 14 weeks. Very exciting. So what we see is that by treating their sleep abnormality with a sleep medicine, we actually have very significant improvement in their pain. The reduction in their pain is actually on par, if not slightly better, than the 3 currently available FDA-approved treatments for fibromyalgia. Next slide, please. What's also interesting is they looked at fatigue, and also you can see that there's statistically significant improvement in fatigue compared to placebo in both of the treatment arms, which stays significant throughout the study. As far as I'm aware, this is the only medication that has been shown to statistically proven improvement in fatigue in patients, and especially in such a large, well-designed, double-blinded, placebo-controlled, randomized trial. So very exciting results. Next slide, please. This shows the Jenkins sleep score. So a negative score is better with this particular scale. The placebo is in beige, and then the treatment groups are in the red and blue. And we can see from the very beginning there's a very significant improvement in their sleep. So not only does it improve pain, but fatigue and sleep as well. Next slide. So what they concluded was that there is a significant improvement in fatigue, sleep disturbance, functionality, quality of life, as well as a patient global impression of change was a composite measure of various questionnaires when we give sodium oxybate in patients with fibromyalgia during that phase 3 trial. Next slide, please. I'd like to move on from the non-refreshing, non-restorative aspect to a very common complaint, which is insomnia. Most patients with fibromyalgia do have insomnia, difficulty both initiating and maintaining sleep. There can be many causes: pain, various sleep hygiene issues, stress, hormonal and neurochemical problems. Stressing good sleep hygiene, a good routine, can be sometimes very helpful. A number of sedative hypnotics have been studied in fibromyalgia, including benzodiazepines, and these are your Valium, Xanax, Klonopin, Ativan type medications. Ambien as well as Lunesta are also in this class. They can be helpful for the short term, however they do tend to interfere with deep sleep when given for the long term. And if we know that there's already a problem with deep sleep in patients with fibromyalgia, I'm not so sure that this is the most clever or intelligent long-term solution because it can actually worsen their deep sleep, and that is already, as we know, a big part of the pathology in fibromyalgia. Antihistamines such as Benadryl can be very helpful. They're fairly long-acting, which is good in certain cases. They're non-addictive. They do have a tendency to worsen restless legs, and that is a condition that's present in a lot of patients with fibromyalgia, so we have to be careful about that. Next slide, please. Medications that worsen and cause insomnia, such as beta blockers, which are commonly given. Can we have the previous slide, please? Beta blockers such as propranolol, Inderal, metoprolol, atenolol can be given in patients with high blood pressure, mitral valve prolapse, a number of other conditions. It can be helpful for tremor, but they can impair melatonin production and sometimes worsen insomnia. The two agents that are FDA approved for fibromyalgia, including Cymbalta and Savella, are part of a class called SNRIs, or serotonin and norepinephrine reuptake inhibitors. They can be beneficial for the pain in fibromyalgia, but they can sometimes worsen insomnia as well as restless legs. A lot of patients with fibromyalgia will turn to energy drinks, stimulants, and that can sometimes worsen their insomnia as well. Next slide, please.